Today, I'm going to have a talk on lessons for post-pandemic antimicrobial stewardship. The objectives of today's talk will highlight the threat of antimicrobial resistance, the challenges of implementing antimicrobial stewardship initiative during COVID-19, and provide an overview of data regarding bacterial infections, AMR, and COVID-19, and then finally highlight the importance of a team-based approach and education. We know the enemies we still need to face after COVID-19 pandemic, that is antimicrobial resistant bacteria. There are news reported pandemic huge surge in superbug infections and death, and also the dramatic rise in deadly superbug fungal infections in US. The pandemic led to surge in superbug infections in European countries, reported from US CDC and EU agents. The antibody use is correlated with AMR, and this had been long understood. You can see this figure show that the relationship between total antibiotic consumption and the pneumococcal resistant to penicillin in 20 industrial countries. And the y-axis is the penicillin susceptible pneumococcus rate. The x-axis is total antibiotic use, defined daily dose per 1,000 population per day. In Northern European countries, the Netherlands, Denmark, Norway, Sweden, Finland, Germany, their antibiotic use is low, and the penicillin susceptible pneumococcus rate is also low. And in France, Spain, US, Greece, Portugal, in these countries, the antibiotic consumption are high, and then the pneumococcus resistance rate is also high. And if you look at the global burden of bacterial antimicrobial resistance, you can see the 5 regions have all age-death rate associated with bacterial AMR higher than 75 per 100,000, including all 4 regions of Sub-Saharan Africa and South Asia. They are all age rate of death attributable to antimicrobial resistance is high. And even in high-income Asia Pacific and Southeast Asia, their all age rate of death attributable to antimicrobial bacteria resistance is also high. The importance of antimicrobial stewardship include 5 key components, including right patient, right antibiotic, right time, right dose, and the right duration. And the challenges to AMS during COVID-19 pandemic, we found that in the health system, the affected area, including overcrowding and overloading of healthcare systems, and this has the impact on major driving for the transmission of AMR. And the depletion of structural resources has the impact on propagation and the spreading of SARS-CoV-2 infection due to cohorting of positive and negative patients, and the rapid reorganization and the recruitment of staff to maintain the institutional memory and the team dynamics within organizations also has the impact on loss of best practice and the leadership within the local team environment. In the hospital and the community, the affected area increased the rates of empirical antimicrobial therapy for patients presenting with respiratory symptoms potentiate the AMR, and the increased rate of telemedicine within primary and the secondary care and the outpatient service has the impact of possible increase in community rates of antimicrobial prescribing as part of safety netting. And then this table showed the association of co-infection with COVID-19 severity. Patient with co-infection versus no co-infection has significantly higher white cell count, neutrophil, lymphocyte count, and the increased levels of D-dimer, IL-6, IL-10, CRP, and the procalcitonin. The co-infection associated with was COVID-19 severity in cold regression, especially in those with elevated lymphocyte count, D-dimer levels. Therefore, the co-infection has impact on the severity of COVID-19. And the COVID-19 associated secondary infection, according to an updated systematic review, the pooled incidence rate of secondary infection COVID-19 was around 24%, and most of them are bacterial infection, and some of them are fungi and virus. The causative pathogen of secondary bacterial infection include Acinetobacter, Pseudomonas species, and E. coli. And there are also virus, rhinovirus, and the Candida and the Aspergillus species. And the result from different studies revealed highly heterogeneous attributable to clinical and epi characteristics of each place, as well as to the diagnostic methods and the criteria used. The local epidemiological report on secondary infection and the risk analysis is important for clinicians to providing proper empirical therapy. There are definitions on co-infection and the secondary infection of the COVID-19. The co-infection has been defined as within 48 hours of the admission, and the secondary infection defined as after 48 hours of admission. Means the co-infection, most of them are from the community, and the secondary infection are from the hospital acquired. The incidence rate of co-infection is 2.5 to 5.1%, and the secondary infection is 3.7 to 41.9%. The site of infection in the co-infection is UTI, respiratory tract infection, skin and soft tissue infection. And in the secondary infection, there are bloodstream infection and the ventilator-associated pneumonia. For pathogens, the co-infection has more E. coli, Klebsiella pneumonia, pneumococcus, Haemophilus influenza, and the Staphylococcus aureus. And for the secondary infection, there are cones, there are Enterococcus, Pseudomonas aeruginosa, MRSA, Enterobacter species, and the Klebsiella species. And this slide, we showed our experience from our hospital between January 2020 and September 2021. We have 204 patients hospitalized due to COVID-19. And the difference between the patient with secondary infection, they have 32 patients, and without secondary infection, 172 patients. The difference in the demographic feature, Carson index, include elderly patients, male predominant, and more severe patients, and the comorbidities, diabetes, mellitus, they are more in the secondary infections. And the impact of COVID-19 associated with the infection is the survival time of inpatient decreased in the patient with secondary infection. And also the hospital stay in patient with secondary infection, became longer. they are become longer in the patient with secondary infections. And for the bacteria, we have 88 episodes of bacterial infection. They are most of them are low respiratory infection. The second one is primary bloodstream infection, then urinary tract and soft tissue infection. And for the virus, we have 19 virus episodes, including EB virus, cytomegalovirus, and adenovirus and respiratory syncytial virus, each one. And for the fungus infection, we have 4 episodes, 3 invasive pulmonary aspergillosis, and 1 episode of epidemia. And if we look at the bacteria pathogen, most of the bacteria pathogens are MDR, such as Acinetobacter, Stenotrophomola, Pseudomonas species, Klebsiella species, Bacterium, Elizabeth Kingeri, and Sphingomonas. And from a review from Carlson et al., they have 85 studies with data for more than 30,000 patients. During the first 18 months of SARS-CoV-2 pandemic, the overall prevalence of bacterial infection was 11%, and the overall antibiotic use was 60%. The empiric antibody use rate was 62%. And the authors concluded that there is currently insufficient evidence to support the use of empiric use of antibiotics in most hospitalized patients with COVID-19, as the overall proportion of bacterial co-infection in this patient is low. However, the antibiotic resistance during COVID-19 actually is very important. The high antimicrobial resistance rate has been reported during the pandemic, including Acinetobacter, Bormanni, and Klebsiella pneumonia. They have over 90%. And among them, most are carbapenem resistant strains. And the methicillin resistant Staphylococcus aureus and the Cons. And the ESP producing E. coli, MDRO, carbapenem resistant Klebsiella pneumonia, Acinetobacter Bormanni, and the Pseudomonas species were high in China. They all exceeding 92%. The risk of AMR during COVID-19, including the safe antibiotic medication and the antibiotic prescription by general practitioner, and the administration of empiric antibiotic prior to ICU admission led to a high prevalence of MDRO. And 100% who had MDR super infection had received broad spectrum empiric antibiotics. The WHO living guideline recommend against antibiotic use in all patients with mild COVID-19, as well as for those with moderate COVID-19, unless there is clinical suspicion of a bacterial infection. In moderate cases, antibiotics should not be prescribed unless severe bacterial infections are lab confirmed or are clinically suspected. The treatment of other co-infections may be based on a lab confirmed diagnosis or EPI and clinical criteria. The Taiwan guidelines showed the guideline recommend against the routine prescription of antibiotics in COVID-19 patients. And the prescription of antibiotics should be based on clinical justification, such as disease manifestations, disease severity, radiographic imaging, and the lab data. And we recommend a comprehensive microbiology workup before administration of empiric antibiotics in COVID-19 patients to facilitate adjustment de-escalation or discontinuation of antibiotics. All hands on deck. It is important to have a team-based approach. The antimicrobial stewardship and COVID-19 preparedness and response depend on teams such as collaboration with epidemiology, infection prevention team. And this team can assist with early case identification, assist with communication, and the also opportunity to longitudinally link programs. And also diagnosis stewardship team coordinate with microbiology and the hospital epidemiology for real-time interpretation of PCR test results or other microbiology data. The treatment team can assist in creating treatment guidelines, anticipate and manage drug shortages, and also assist in completing electronic investigational new drug and the local IRB paperwork for emergency use agents such as remdesivir, and monitor enhance compliance with local treatment guidelines. AM's initiative halted during COVID-19. Most established antimicrobial stewardship programs were discontinued during the pandemic. Over 60% of ASPs reported that COVID-19 had a negative impact on the routine AMS activities, with a decrease in stewardship rounds, multidisciplinary meetings, and point prevalence surveys. Resources and staff were reallocated to contribute to COVID-19 pandemic response. This resulted in increased AMR rate. Lessons from the COVID-19 pandemic. The first, sufficient economic and public health resources must be allocated to healthcare facilities to have a stable and structured ASP. And it is critical for MS initiatives to continue during a pandemic. Infection prevention is central to ASPs. COVID-19 pandemic overwhelmed healthcare, and so many IPC programs lost progress. And healthcare facilities need to be built and structured so that they can withstand the surge of the next pandemic. In summary, antimicrobial resistance is a serious global threat. Patients with COVID-19 are receiving a high rate of inappropriate antibiotic use. The rationale for antibiotic use in patients with COVID-19 seems to be based on the clinical judgment with bacterial superinfection in influenza. It is important to judiciously use antibiotics during as well as post the pandemic, as antibiotic development is fragile. All hands-on-deck approach is needed, and we should have the global vision on AMR, and we should have the local action on AMS. Thank you.